Okay, well, I just figured we'd get started at this point. I'm Al Geisley from Carolina Orthopedics. I'm glad you're all here tonight. Welcome to this talk. We're going to discuss some things about spinal disorders from the top to the bottom. And I have a non-electronic slide advancer here, Michelle, but the electronic slide advancer is coming. So if that shows up, we might take a momentary break to change the computer around. But otherwise, go ahead. Again, welcome. This is I'm with Carolina Orthopedics, and our sponsor tonight, co-sponsor, is Fry Regional Medical Center. Next one. And what I wanted to talk to you about tonight is a variety of topics. We can go over all these or some of these depending on questions and how time works, but I wanted to start out with looking at things that most all of us can relate to in the so-called mature spine, or what goes on when things, as we age and your spine wears out. Look at a little bit about neck pain and treatment of neck disorders. Touch on scoliosis briefly in the pediatric population. And then just to top the evening off with something that you don't hear about very often, but a common but uncommon source of back problems, the sacroiliac joint. So what's my background? I trained in the Army at Walter Reed. I did my residency there, an internship for 5 years. And then they sent me to work at Fort Campbell with the 101st and the Special Forces people, and they did all kinds of fun and interesting things that I got to help them with. And eventually, after doing general orthopedics for a couple of years, doing arms and legs and shoulders and such, I decided I wanted to specialize in the spine. So I did a fellowship, extra training in spine surgery at the Twin Cities Scoliosis Center in Minneapolis, which is affiliated with the University of Minnesota. And after that, practiced for the Army for a couple of years doing exclusively spine surgery. And then I've been here in Hickory since 1995, which is my first and hopefully only stopping point after getting out of the Army. So this is something I've done a fair while, and I've done it here in your community for a good long while. Next one. So just to kind of look at, what's the anatomy that we're looking at? We're all familiar with this, but it's worth reviewing. The bones in the spine, of course, are called the vertebrae, and the joints in between them are sort of semi-moving joints called discs. I think of them like bushings, more so than the moving joints in the hips and knees that we're used to thinking of as joints. The idea behind the spine is to serve as a support for the rest of our body, but also as a housing for the central nervous system, the spinal cord and nerves that work our arms and legs and everything. And so those go through the back of the spine, as you know, and then at each vertebrae level there's a little nerve that exits and goes to whatever pertinent body part that level of the spine controls. Next one. So if we look at the so-called mature spine, I wanted to touch on three areas that are fairly commonly dealt with and that probably affect most all of us at some time or another. Spinal stenosis, instability where the spine moves too much or doesn't stay properly aligned, and then another fairly common problem, compression fractures. So what happens as time goes on? Various changes occur in the anatomy of our spine as it ages or wears out. This little diagram here shows you what the normal disc is supposed to look like, and then you always hear about these other kinds, bulging and degenerated and herniated discs. What does that mean, or what are those things? This little drawing here sort of shows you, gives you an idea of an artist's representation of what those look like. Degenerated mostly refers to when the disc itself wears out. It becomes an incompetent shock absorber, and it gets sort of what we consider, quote, arthritis, or what is commonly called arthritis. In medical terms, we would call that degeneration or wear and tear. Any number of terms would apply. As part of that, and this doesn't show that over here, as the center part of the disc wears out, the lining bears all the force. And so the back wall and the side wall and all of the walls tend to sag out, just like most of our midsections do, right? As time goes on, this is normal for all of us. And so the lining bulges, and so you hear about bulging discs. And a true bulging disc is really a normal part of the aging process. The lining sags outward as the central part tends to wear out. In some cases, with some bone spurs, that can cause problems with the pinched nerve, but in other cases, in fact, in most cases, that's really a normal variation. That's just like saying I have a few wrinkles or gray hairs. That's kind of, I'm supposed to have those things. But when some of the jelly squirts out, And if you think of it as a bushing, but also like a jelly donut, there's a hydraulic jelly in the center that supports all the force. And if a weakened area develops, some of that jelly can squirt out and pinch a nerve. That's a different thing. And it sounds like the same thing, but it's bulging or it's herniated. Well, if you know someone that has a hernia or has had a hernia, you know, if your belly bulges because it's sagging, that's one thing. But when you have a hernia where there's a little spot in one area where something pokes out that's not supposed to, that's really what a herniated or slipped disc is. And that typically will go back and pinch the nerve tissue. It will inflame the nerve tissue, and that can cause a lot of discomfort in some cases. Interesting part is a lot of those, when you see them on MRIs, don't cause any pain at all. Most of them are silent or what we would call asymptomatic. So herniated and slipped, another term that's commonly used is ruptured, all mean the same thing basically. This is a diagram here that shows a disc that's thinning. That's another finding you might see on pictures, MRIs, X-rays, where the substance in the middle is wearing out and the disc is degenerating, another simple aging change. And more commonly what we see is a combination of these kinds of things where the margins are not completely intact, there's a little sagging of the lining, and there are some bone spurs that form around the edges that the body develops in an attempt to stabilize the joint and give it more stability as it becomes less and less competent. And so these things which result in some stenosis or nerve impingement and loss of stability can cause pain in a variety of areas in the back and leg, hip area that we're probably all familiar with. As we're treating these, our goals are fairly obvious. Everybody would like relief of their pain. We, as surgeons, strive to do that. We strive to correct any problems with malalignment, which often underlie a lot of the discomfort, as well as nerve impingement. Try to restore mobility to the person in general. Sometimes that means taking away some of the mobility in the spine, which seems sort of counterintuitive at first, but it actually helps. And the big bottom line picture is let's improve quality of life. Let's make you try and get rid of as much discomfort and make you as functional as we possibly can. You know, surgeons, what do? They want to operate, right? We all know, and we're all trained how to do that, but probably 90+% of the folks that come into a surgeon's office doing orthopedics are treated non-surgically. And the reason is that most things that we all come in with to that person generally can get better without surgical intervention. The hallmark treatments that we use include some kind of pain medication, and actually probably shouldn't use the word pain medication, maybe other kinds of medications that help with pain, such as anti-inflammatories, and also sometimes painkillers are an important part of that. We routinely rely on certain injections into the spine to help reduce pain or help diagnose where the pain comes from. Exercise to stay active and functional and improve range of motion, and physical therapy is another very important adjunct. So with this combination, many people can be not necessarily made normal, but be gotten better and more functional, have less pain, improved quality of life. Surgery is reserved for the minority of individuals where those things don't help or don't help enough. It is certainly not a cure-all or end-all treatment. Sometimes it's the last step in a chain of multiple options, and will often, for certain disorders, give us the best results. When you look at what we're going to talk about tonight, and for the most part in spine surgery, there's really two main things we do. We decompress or take the pressure off of pinched nerves or spinal cord. So if something's too tight, we make it open or looser. And we have joints in the spine where the disc is either too loose or worn out and incompetent, and in that case we stabilize it or make it more stable by fusing it and try to reduce excessive or abnormal motion. And then of course there's some things that don't fall under every one of these categories identically. We treat specific conditions that require other treatment differently, and the example I'm going to use tonight is just to show you what we do or can do for compression fractures in the spine, which we'll get to. So the question came up earlier, am I going to talk about stenosis? What is spinal stenosis? That's the medical term or jargon for when we have narrowing. We can have coronary stenosis. You can have stenosis in your GI system where there's a tightened area. And in the spine, of course, it's pretty simple. You can have spinal stenosis. which basically means that there's impingement on some structure that's supposed to go through that part of your anatomy. So in the spine, of course, it's the space, as I showed you earlier, where the spinal cord or the nerves come through or out to get to their destination. So the healthy segment, when you look at a cross-section, what you might see on a CAT scan or MRI, kind of in an artist's representation, you have the disc here in the front, the lamina or the bone on the back here is what you feel on your back, is those little, bones on the back of your spine. And that houses the nervous system in here in this open area. Below a certain level, there's actually not a spinal cord. You'd be interested to know. Many of you do. But there's just a whole collection of nerves that come off of the end of the spinal cord, and they float around in spinal fluid like you see here. And there's plenty of room for all that tissue, and it kind of is protected by the nervous system. When you have the development of abnormalities, next one, such as spurs, thickening of the ligaments, you can see how that space gets narrowed down, and the nerves both in the middle here, on their way out and on their way toward the way out, can get trapped and pinched. And so those are the findings that we call spinal stenosis, and that can be due to a variety of different things that go on with the anatomy as it ages. If it's in the middle, we call it central spinal stenosis. If it's under this edge of bone that the nerve travels under before it leaves, that's called lateral recess stenosis, because that's what that area is called. And then the little opening here where the nerve comes out is called the foramen. That's called foraminal stenosis. No quizzes, by the way, on the terminology, don't worry. But any number of those places can be affected, and the critical thing is we have to really look at all of them, because the nerve doesn't know if it's pinched, that it's pinched here or there or there. All it knows is it's pinched, and it's going to tell your brain, here's the problem and here's where it is, and it's our job to figure out where that problem is. This can get pretty complicated because it's rare for, think about it, all these tires are put on the vehicle at the same time, right? How often does one of them wear out and all the others stay great? All these discs sometimes at a certain point in our lives look funny, and you can see abnormalities, and so we really have to go through a lot of asking you questions and trying to get fine points of information to help sort out how is what you're here about, how does that correlate with what is on these pictures, so that I can resolve it to something where I can tell you, well, the reason why is this, and this is what we can do about that. Because sometimes it's very broad and all over the place and very difficult to pin down to one area. Next one. So again, just to reiterate a little bit of a better picture, spinal stenosis symptoms, we really go over the history and try to pull it out of you. You may tell the doc a lot of things that are important to you. Sometimes they aren't really helpful for our understanding, and we'll say, well, what about this or what about that? And you say, why does he care about that? Some of these features are so characteristic that if we don't hear them, we're probably barking up the wrong tree. And if we do hear them, we know, okay, I almost don't need to know more. I've got the diagnosis figured out. For spinal stenosis, the classic thing that most everybody has is they get pain with standing or walking that gets better when they sit down or lean forward. And now that you understand the anatomy, you can see the why behind that. When you stand, you don't feel this, but you naturally align your spine into more of what we call an extended position like this. And any potential narrowing where the nerve runs or runs out through gets tightened up, and the nerve gets pinched, and it tells you, okay, you're going to hurt. When you sit, again, a non-conscious thing that happens is your spine aligns itself more like this, and it makes more room. And so I sit down and I feel better. I don't understand why. You're making a big change in the alignment, and the nerve is kind of getting a sigh of relief and saying, okay, I can recover now and feel better. So many people with spinal stenosis have to sit down to gain relief, or if they can't sit, lay down. Or if they can't do either, they have to lean over and make more room, and then with a little bit of time, things feel better. So what do we do for that surgically? If it's too tight, I mentioned earlier, we make it looser or open the space. And the classic procedure for that is called a laminectomy, because we take off that back arch of the bone called the lamina, and the principles are relieving pressure. Laminectomy is generally what's done with stenosis because it's mainly a bony issue. We take that bone away. Sometimes there's a bulging or herniated disc that contributes to that as well. And so you really have to do a house cleaning procedure. You can't just take out this and leave that. We have to get everything and anything out of there that impinges or can add to the impingement. It may include the disc or part of the disc as well. And you can see here kind of this thickened arch of bone and the little irregular areas that lay underneath it that we remove and then make more room for the nerves. So we go from this condition here to this situation here, and that will generally take care of it. The assumption is, of course, that this hasn't gone on so long that the nerves aren't damaged. If you wait too long, or if you have certain medical conditions where pressure can cause nerve injury over time, you can do this and have a beautiful post-op MRI or X-ray, and you can't make the person entirely better because the nerves have damage. And that's why we try to take care of this as early as we can, but as late as Mother Nature will let us. We don't want to do unnecessary surgeries, but we don't want to let people go on and develop permanent problems that they can't recover from. So what about instability? What about this whole idea of fusion? Instability, of course, implies excessive motion between the vertebrae, and because the purpose of the spinal column is to protect the neural elements, the spinal cord and nerves, if it moves too much, it's not going to act as a good protector, and the abnormal motion will hurt both because the joint pops back and forth like a trick knee, okay, no real nerves in the knee per se, but also because as it does that, it can yank on or pinch the nerves that are housed inside of it. So a lot of reasons why excessive motion can cause trouble. And this is an example, probably the most common type that we all see and we treat, where you have a vertebra that slips out of position and moves back and forth like this. It's typically due to some kind of incompetence in the little joints on the back of the spine that restrain the vertebrae in place or control their motion. And you can see how this puts in a lot of added strain on the joint, which makes it wear prematurely, but also you don't need any experience reading MRIs to figure this part out, right? So we want to limit that excessive motion or eliminate it in cases where it's causing trouble. Next one. And what does that involve? You know, stabilize the spine or fusion. A lot of people, you know, fusion is sort of the F word, right? No one wants to have a fusion. No one wants to even talk about it. And we don't really necessarily want to either. But there are times as surgeons, that's the only option we have left. If it's too loose or it's not protecting things, we have to stabilize it. And there's not too many in-betweens for those cases. And that involves, people are always concerned, are you going to do it with rods and screws or whatever? I said, no, I'm not. I'm going to do it with bone graft. And this is sort of a simple but important concept. The fusion really involves making the vertebrae grow together into one piece by fooling the body into thinking that there's a fracture. You know, what do you have in a fracture? You have damaged muscle, a little bleeding, bone chips, scratched up bone, whatever. And the body interprets that as a broken bone, and it grows the pieces together like it's supposed to wherever the bone breaks. We replicate that in the spine and in other, you know, bony areas by scratching up the bone and putting in bone chips and letting the body try to grow it back together. The hardware that everyone gets excited about, and you know, it's very impressive and frightening looking on X-rays, is a helper. It's really not the operation. I mean, spine fusions for this kind of stuff have been done since the early 1900s. There was no such thing as hardware back then. It was just simple biology, put the bone chips in, and those were the days when people stayed in bed for 9 months or a year, or wore a body cast for a year and a half. And that was an attempt to try to do what our modern instrumentation here does internally, but it was not that great. So we have better success with the hardware because it makes it more predictable, but it is an adjunct. It is not the operation. These are little diagrams of, you know, what the bone chips look like. That's really what the operation is. And there's two main ways that we do that. One is we lay bone chips along these back parts of the vertebrae, the posterior elements, and they just kind of grow across here eventually. And the other way that's commonly done is we cut out or replace the entire disc with bone, sometimes just bone, sometimes a big strut of bone. Sometimes in there with the little chips we put a cage, which is a mechanical strut that keeps the vertebrae from collapsing onto those chips while they're still kind of tender and fragile and haven't consolidated into one piece yet. So this is an example of that, where you have bone chips, and here the artist put in a little piece of bone, probably from a humerus or from a femur, or we borrow that from a donor and put that in there with the bone chips, and that keeps things from collapsing as it heals. And of course you can see the rods and screws right there. Next one. This is just, I just tried to grab a representative out of my X-ray server, and this is somebody that had some instability. We were able to get the vertebrae lined back up. It was a case where, like on that drawing, where the vertebrae wanted to slip back and forth out of position, so it's lined back up. There's a cage in here which is made out of a high-density polymer, a plastic-type polymer that is similar to the density of bone, and it has spaces inside of it for bone chips to go in. But of course it's plastic, so where is it? You know, do you know you put it in the right place? Do you know it's still in there? They put these little metal markers in it so you can track that and observe it on X-ray, and that's what those are, little tiny metal markers that show us the position. That way we can watch from time to time. In there with it are a bunch of bone chips, and most of us, in this case, we try to do a job where we know if it doesn't heal, we've done everything we can to try to get it to heal. So we fuse the front, and commonly when we're doing that, we're going to also put some fusion bone in the back to back that up and give the broadest surface area for bone to grow across to make this work or give it every shot that it can. And so this is kind of on X-ray. You can see the little bone growing between those two spindles, the transverse processes here and here that were on that diagram. And this one looks good. This is somebody who has a solid healed fusion, and they're doing well. Some newer techniques and newer technology that we have for doing this, that procedure is done all through an incision in the back. Well, sometimes it's easier, better, or more effective to gain access to the disc. Where is it? It's in the front. You know, we can go in through the front, and there's a variety of ways to do that, but we do have some newer, more minimally invasive techniques where you can do that without all the trauma that we used to have to do. And this is one example, this direct lateral interbody fusion, meaning between the vertebrae, where we can make a small incision in the flank, get to the disc, and put a different kind of a cage in there with bone graft or bone graft substitute. And then that's usually backed up with some hardware that's put in the back, which you can do through little incisions, minimally invasive incisions, and all this can be put in through several little stab incisions in contrast to the open way. Is that better or more effective or what have you? It has a lot of theoretical advantages. It's not for everybody every time, but it's another newer option, sometimes allows us to accomplish that goal, just another method of doing the same thing. And next slide. And if you see here, you can see this is just a little, almost a video of how that works. The retractor is in there that comes through the flank. The organs and the nerves are pushed out of the way. And then the cage is this device here. This disc space has already been cleaned out, all the materials out of there. It's scratched up and irritated and ready to be told, okay, you're a broken bone, grow together, right? And the cage is going to be inserted, and if you just hit that each time, Michelle, you can see the cage moving in, and moving in, and there it is, I think one more. And there it is situated in the disc cavity. And so that takes care of the front part. Then that incision gets closed, and you can flip the person over and make some smaller incisions on the back and go ahead and put that hardware in to back that up. So that's fusion. What about compression fractures and broken bones due to soft bone in the spine? That's the third topic in the mature low back area. And let's go back one. As we know, and you can see this is a sort of an artist's representation of that, but the bone structure tends to thin and weaken as we age, and this happens in everybody. Some people are more at risk for it than others, but when it gets weak enough, like this, and you can see that the little spindles of bone that connect all of our parts together get thinner and thinner. They're less capable of working. They can collapse under normal working conditions, bending, twisting, lifting items, or more involved stuff, falls and so on, are very common as far as causing fractures. In 2005, one of the big public health organizations added all this up. There were about 2 million osteoporotic fractures in the U.S., and the majority of those occur in the spine. So it's an area of interest to folks that treat spinal disorders, and an area of interest to all of us as we age. And as I mentioned, the things that do predispose one are a variety of factors, age being probably the most common one because that does this to everyone. But heredity, lifestyle choices, nutrition, some medications, and certain other medical conditions can all add to the weakening of the bone and predispose us to this type of thing. So about 10 million folks in the United States are going to have significant weakness on a bone density test that are predisposed. The overwhelming majority are women because of biological factors with estrogen, loss of estrogen, childbearing, and calcium mineral leaving the skeleton for the baby. And the fact that once you lose your estrogen function, there's a lot of mandatory calcium loss out of your bone that you can't control or can't limit unless you stay on estrogen after menopause. If you're over 50 in the United States as a female, you have about a 1 in 2 chance of getting some kind of an osteoporotic fracture at some point. Big statistic. For men, we're a little bit luckier. We have other problems, of course, but it's still fairly common as the population ages and gets older. You know, the estimated lifespan increases and we're all here longer on planet Earth. Men are getting more and more of these, and men are showing up with other medical conditions and treatments that predispose them, and we have to think of them too. It's not just a disease of women. And as that slide suggested, it's almost 600,000 fractures a year in the spine, so a big problem. Next slide. So what do you do, or how does one prevent that? What can you do to stay on top of this? Good nutrition, calcium and vitamin D supplementation. These things don't make your bone get stronger once you're past about age 30, 35. We can increase our bone density through dietary intake in our younger years, but once you get to that age, give or take, all it does is slow the natural rate of loss that we all experience later on. And there's a slow, mandatory leaking of calcium out of our bone as we age. Weight-bearing exercise and resistance exercise, things that put mechanical force across our bones, light upper body resistance exercises, walking, jogging, running, anything that puts a pounding or repetitive cycling force through your bones will give them a reason to say, I realize I'm being used and worked, and that, through the little microhormones in the bone, makes the bone tend to stay stronger or get stronger. And the opposite is also true. If you put a person to bed or they don't step on their broken leg for X number of weeks, that area will lose bone density tremendously just due to the lack of force application. And that's why we're always jumping up and down and saying, get out of bed, get moving, get out of bed, get moving. I hurt too much, I don't feel like it. It's critical because you lose a lot of bone density with immobility. There are a lot of things to be considered, and you know, you need to talk to your family doc or come in and see your orthopedic doctor about that. Once it's established that the density is low enough, the only way you can really rebuild it isn't this, but you usually have to work on a multi-phase program of medication, exercise, and then supplementation of calcium and vitamin D to make sure you can rebuild the bone. Next one. If you break a vertebra or have a fracture, what's done about it kind of depends on the specifics, and there are all kinds of ways to manage this. What it looks like kind of in an artist's conception is there's a little series of cracks through the vertebrae which is shaped like a rectangle or a cube. So one of the hints to us that there's a fracture is that the vertebrae is crunched down, it's shaped like a wedge or what have you, not a triangle, or I'm sorry, not a rectangle or a cube. And we, just like any other fracture, if these are fairly minor and not notably displaced or crunched up too badly, we treat these non-surgically and they almost all heal. It takes 3 to 4 months for the bone to grow together, and we try to keep you comfortable with some medicine. There may be instances where a brace will help. They're hard to tolerate many times. If you have a thin, relatively trim waistline, they can work. If you don't, sometimes they just can't hold your spine and they don't work, and so it depends a lot on the individual and their body shape. But the biggest thing is really this right here, time and patience. It just takes time, and you can't really force, you know, the car to the finish line through the checkered flag any faster. It just goes at its own pace, and that's about 3 to 4 months. Once you're better, or if you're not getting around well, there is a role for therapy to help you recondition, strengthen, help strengthen your bones for the future, and mobilize if you can't make it well on your own. If it hurts too much, or if there's too severe involvement, if you're not able to tolerate that time and the conservative treatment, there is a nice technique called kyphoplasty. There are other variations on this. This is what I happen to do, where we can treat that with a minor surgical procedure that's generally done as an outpatient. And you can see here's what it's supposed to look like when you have this fracture. It's crunched down, the shape has changed, and there are cracks in the vertebra. Next one. And so what's done with kyphoplasty, we try to stabilize those cracks and try to correct the shape. Correcting the shape is sort of a secondary goal. The main thing that hurts isn't the shape, it's the cracks and the instability through those pieces. So we make a couple of little incisions on your back under x-ray, under fluoro, and pass a special tube down into the vertebrae through the same part of the bone where you saw those screws go through earlier. It's called the pedicle. It's a nice area that you can put something through from the back into the front. And we drill a little channel, and then we have a special balloon that goes in there. You can inflate that and sometimes restore the shape of the vertebra, sometimes not. But the nice thing about it is that you create a cavity in there that allows you to inject some bone cement under low pressure, fills this cavity, and then it kind of oozes out from that cavity through all the cracked areas, and it can spread into the cracks and stabilize them immediately, almost immediately. And it looks kind of like this in the artist's conception. When you catch these early and they're not too collapsed, and that there isn't another source for the pain. You know, somebody like this might be at risk for having stenosis, and they have stenosis pain and they have instability pain. Oh, by the way, I broke my bone. But if you have purely fracture pain and you can catch this early, if it's too much to put up with, this helps people just about overnight. People are about 90+% better. I mean, they kind of come in, it's one of these real Grand Slam home run things where it's, feels semi-miraculous. They feel fantastic and so on. This is not what happens for everybody, and I'll be the first to tell you I don't have that happen every time any more than the next guy. That's very difficult because most of the folks with this have other issues, and you can't get rid of all of them with this. But to the extent it's from the fracture, it's a great thing. This is an example from my practice, and it just goes to show you there's the kinked over vertebrae, right? Anybody can see that on x-ray. It teaches us two things. Once it's kinked over, sometimes it's always kinked over. So when you come in for your x-ray, say, my back hurts, I fell, now it's killing me. And we get an x-ray and we see that, it may be an old one that's healed. And so we generally can't tell you that. We have to do some special testing to sort that out. And the two main ways we diagnose that, is this acute or is it an old healed one, is with a bone scan, which involves a nuclear medicine test. They give you an injection of radioactive bone tracer, or an MRI. And the MRI is nice because it doesn't involve radiation, and it shows us the anatomy. This is an example of one of those where you would say, well, maybe it's something else, because if you look at the x-ray of this person, this isn't really kinked down that much. It's not really crunched over into a little wafer. Sometimes, by the time the person comes in, this thing is down to a little pancake. You know, it's very obvious. But this one looks relatively normal on x-ray. When you look at the MRI on these pictures, the normal vertebrae, the marrow in there is sort of whitish. And if there's any swelling in it on this type of picture, it'll look dark. So you can see the upper end of that vertebra has this dark discoloration. That's swelling or edema or excess fluid from the fracture. This is a fairly fresh fracture that typically, as they do, involves the upper end of that vertebrae. That's where they most commonly occur. This kind of series of pictures does the exact opposite. Marrow is kind of grayish dark, and so fluid or water type stuff looks white. And you can see very clearly the upper end of this vertebrae has a lot of edema. This is a fresh fracture. The anatomy is fairly well preserved. This is somebody who could probably benefit from a kyphoplasty or some type of cement procedure for the vertebrae. Next one. And this is what that looks like. This is that same patient after treatment. This, one of the critical things, the cement has to get up to the area of the fracture, not just spread through the vertebrae. And this person went home later that day, a couple hours afterwards, and did very well. The big thing is always about, I think the next slide. An ounce of prevention is worth a pound of cure. This is a grandmother, mother, and the daughter. And you can see what happens here. This lady, unless she gets treatment and works on prevention, she's going to wind up heading in this direction. We can treat these and react to them, but it's way, way better to never have this happen in the first place, because when you get to this point, or certainly to this point, the horse is way out of the barn, and there's not a whole lot that one can do. And the other point to be made is that person with the nice cement procedure and who's doing better, well, the other vertebrae are still weak, and we get excited, we do a high five, and they're better, they go home, they love you, you love them. They could still break the next one. They could still break another one next week. And so the big thing is those folks, You have to always go and get that bone density measured if you haven't, and you have to see your doc or somebody else that treats this. And the real important step there is not the follow-up, it's go to the osteoporosis clinic and get started on something to prevent the next ones. So there was a question toward the back.